All right, good morning, everyone. This is Dr. Tran again, and welcome back to my weekly rounds. Well, today, I haven't seen any of you guys yet, but we'll talk about history-taking skill. This is the most important skill that you need to have if you would like to become a great doctor. Give me 1 second then when I post this online. All right. So I'll go over the basic history-taking skill with you guys. And in this particular video, I'd like to tell you, if you were a medical student, especially first year, think about what I'm trying to present to you today, because they could change your entire career. If you are a better history-taking physicians, you're likely to get a better information from the patients, and therefore, ultimately, you make a good or correct diagnosis. Okay. And I'd like to welcome Dr. Dinh Nguyen. He is one of our medical English instructor from VietMD, and he will join me today as well. All right, guys. So the first thing whenever a patient comes to you, when you talk about history, is the chip complaint. Why the patient come to see you? And
Được xem hả? Thế sao kỳ vậy? Mình đã lót vô account của mình rồi thôi, để đừng đi ra nữa. Không biết tại sao.
Well, let me see. Okay. All right, I think Dr. Dinh will try to log in at the same time. Anyway, so let's start with the basic first. When the patient come to see you, they must have a chip complaint. Like why they like to see me or see you. And from there, the chip complaint, sometimes it could be very simple, like chest pain, or a chip complaint could be something else that it's called hidden agenda. That means they don't want to tell you first. For example, I had a patient a couple of days ago come and see me, and he just said, okay, I want some medication refill. Well, it turned out that this gentleman have erectile dysfunction, and he doesn't want to talk about that with my front staff because, I mean, for a 60-year-old guy come to a doctor office and ask for a medication to help with his sexual activity would be a shameful, and that's why he didn't ask. So this guy come and see me, and he talk about high blood pressure all the time. But in fact, what is his pressure? His pressure is 120 something. In fact, there's some recording. His pressure was 110 and 100, and that puts some serious contraindication with Viagra or any type of erectile dysfunction medication, because you may make the patient even hypotensive. So you can see that patient complaint may be different than what they actually want to tell you. Okay, so let's go to a more detail. How would you ask a patient history? The first one is the old card that I told you over and over again, OLDCARTS. So old card is an onset of location, where and basically where the pain or the complaint started. For instance, if the patient comes with a chest pain, you may want to ask where and when the pain started. So the onset a day ago, 2 hours ago, or 2 months ago would make a big difference in terms of diagnosis. For example, if chest pain just started a couple of hours ago, and for a gentleman that truly have some cardiac risk history, then that could be considered cardiac chest pain if the patient smoking or age appropriate. However, if the patient have been chest pain for months and the chest pain started mostly at night when the patient laying down, or when the patient have before and after meals, I will consider more GI related. So the onset of locations will tell you a little bit about the diagnosis already. Therefore, whenever you see a patient with chip complaint, always try to when the symptoms started, when the rash started, when this lesion started, and when chest pain started, when the abdominal pain started, or even with depressions, when you feel depressed, and those will give you some history, whether it's acute, subacute, or chronic. The next one is usually come together as L, location, right? So when it started and where. For example, the chest pain example that I just told you guys, they may start at the substernal, or it could be a little bit below the substernal. And sometimes the chest pain, not always cardiac, may start. Let me see. And then are you still there? Okay, so let me keep going. Well, the chest pain is not over. Yes. Mm-hmm. And then feel free to jump in. I'm talking about OCA right now, and we talk about the locations and how important location is in terms of history taking.
Okay, and, yeah. Mm-hmm.
I'm sure you guys know Dr. Nguyen. He's one of our, actually, he had 2 books already for the medical English, and has been used as one of our main textbooks in our medical English classes. All right, so the location is the one that will tell you a bit about the diagnosis, and also could tell you about what prognosis is. For example, if this is a chest pain that we're talking about a guy 40 to 50 years old, smoking, have some cardiac history before, and now the chest pain similar to the one he had in the past, then you may consider, oh, this could be cardiac or heart related. Now, durations are D in this OCA, and also give you some idea how long the symptoms started. And remember, durations, it could last years. It's not just second or minute, but it could last for years. If a patient has a chest pain, it lasts for a couple of minutes or seconds, and then it's go away, and then it's improved with rest, then the duration can tell you about some of the nature of the chest pain. But if somebody have chronic back pain for years, that's you think about something more chronic. All right, so at this point, let me have some more interaction with you guys. Actually, I just saw one of you and just disappeared. Okay, and then any comments so far? We'll talk about OCA, and what is your experience with our students in Vietnam when they apply OCA? Can you tell us?
Okay, usually that they couldn't remember the whole OCA because it should be like to make a practice, like anytime you make an interview to the patients, you have to do like automatically. So it needs time to practice it. Anyway, number one. Number two, you don't need to do it in orders. Okay, but at least you have to do everything about it. And number three, about the T and S, the last letters of the OCAs, is a lot of resources are quite different, because some resources, they say that T is timing, and the one T is treatment, but it's up to you, okay? Because the timing, they say that, and S, they say that severity. So to me, it's good idea that to replace T and S by T, that is treatment, is easier for everybody to remember, because the severity maybe belongs to the characteristic. you see from the C. So it's up to you. But that is just a guideline for you to make the question, to make the interview. However, it's not necessary to follow the strictly order, but have to be in full all the letters from the all cards. That's my opinion. Yeah.
Yeah, exactly. And then that's a very good point, because you guys don't have to. And one of the things is, it's funny, some student look at that and they say, oh, wait, this is O, I did say that, L, D. No, you don't have to get an order, okay? You can get in anywhere or any orders, like and Dean just mentioned. But the point is, those characters just remind you to make a better history taking skill. And as I say, practice make it perfect. I don't know if you guys know this. Just yesterday, actually 2 days ago, SpaceX, they just launched the Falcon Heavy rocket. This is, in our human history, the largest or the most powerful rocket that ever go to space. I mean, a lot of people see that it's so easy. I mean, you just hit a button and you count out 10 and until 0 and you go there. But actually, you don't know that people have practiced almost 1,000 times on computer. Like Elon Musk, in one of his interview and also in his book, mentioned in SpaceX program like this, you know, their engineer work 24/7. They try, they practice. So, and even with that practice, you see that there's still one mistake, or not mistake, but like not perfect. When the rocket come up, had the 3 boosters, 2 on both sides and 1 in the middle. The unique thing about this is when it come out there, the booster come back and recover and land it exactly where it's supposed to be. And only 2 out of 3 landed. The third one, when they go out there and can come back, one of the engine, that's 3 main engine and booster, when they go back to the Earth, has failed to start it. And that's why the third rocket, it's to come back to us, but not on the correct location. But I just tell you, even with practice 1,000 times on computer, there's some mistake. It's not a mistake. I mean, the way that I see it, we're just improving. Go back to you as a student, especially first year, second year, third year medical student in Vietnam. Think about it. Even in Vietnamese, what is your main complaint? What is your chief complaint when patient come to see you? You don't go to see a person for no reason. And from that reason, you go on. Well, so we talk about onset, location, durations. And now the curve, like Dr. Dean Nguyen mentioned, the TS, I also agree with Dr. Nguyen about the T. I prefer to use a treatments. Because timing, if you think about it, duration already cover that with a D. So timing, and then some other people say interval timing, like, but I think duration should cover, but it's the treatments, because what have you tried also important. So let's go on. We talk about OLD, let's talk about C. The character is so important when you ask about pain, because if you in pain, there's a lot of characteristics of pain. Dull pain, sharp pain, burning pain, whatever pain that you have, even low pain. Okay, when somebody break up, that type of pain is called low pain, because it's hard to describe. But I'm sure you guys know that anyone in life, you ask about how painful when you break up, that's a type of pain. So the burning sensation when you're laying down and you feel like sometimes sour taste, will think that this like the stomach origins, and the chest pain with those characters will likely come from GI source rather than cardiac source. Versus if you have a rheumatoid arthritis pain, hand pain, joint pain, this pain actually is quite different than the pain that people have with osteoarthritis. The main thing about it is, beside the pain that they have swollen pain that they feel like their hand, their skin is really about to break. And also they have some sensation change too. So that type of pain, when the patient telling you, is not a pain due to degenerative disease like osteoarthritis. And then the character's pain, it's, for example, headache will tell you some of you will tell you this is the worst headache ever, versus, oh, this headache, I can handle that. So characters. And now C, associate symptoms. This is also crucial because, for example, if this is a GI type of pain, abdominal pain, but they come with nausea or vomiting, the gut is so awesome in terms of whenever the gut is not happy, there's two ways they can get the food out. The first one is what? Vomit. And the second one is diarrhea. Then gut, believe it or not, they have a brain within that system. Sometimes when you talk about gut feeling, actually that gut feeling has some science behind that. It's not just gut feeling. It is that small brain in the gut and telling you that something is not right. If you have abdominal pain and gut will telling you that, okay, this was not good for me, and it was nausea, vomit, or sometimes infection, or sometimes that. Again, those feelings come with GI symptoms, and then it will associate with nausea, vomiting. Similarly, people with gallstone or cholestatic, acute cholestatic, they may have nausea, vomiting, versus abdominal pain due to an aorta rupture would be a different scenario. People not likely to have nausea and vomiting because this is from vascular causes, not cardiac causes. And then any other comments?
I think all the letters from all cards, the most difficult or most that you have to elaborate is the C letter, because there's so many questions around the C, about the onset, location, duration. You can pass through very quickly, but the C, you have to lingering and you have to go around there. And especially with the, because that all card can apply when you're questioning about the pain of the patient, but at the same time, you can apply to the, like say that vomiting or diarrhea, you still can apply somewhat of the OCAR framework too. But mostly in pain that we usually use that. And don't forget that we have to ask the patient the pain rate. It's on scales from 0 to 10, because usually pain is very subjective and no machine can measure it. So you totally believe on subjective feeling of the patient, but how you compare, just only the patient compare about that. So you have to ask them to rate the pain by themselves. Dean, Mike, yeah.
Thank you, and then that's an excellent point because the character alone, it could be one of the most difficult for you. But if you actually forget about everything, I recommend the onset, location, and then the characters. And those will give you a lot of idea. A character's pain or the character of a rash or the character of symptom will tell you a lot about what may happen with the patient. I always tell my student here in the US that you're a doctor, but think about you're also investigator. It's a job, it's fun. You come there after an accident, you try to figure out what went wrong. And it's not a pleasure to see an accident happen, but in the same way, if you think about what happened before the accident caused this person die, we push you in a more serious role, an investigator. Well, some of you are become family doctor or even subspecialist. Your job somehow was similar to an investigator because you not only to figure out what the patient telling you, you always try to figure out what is actually truly behind the scene. As I said earlier, my patient come for erectile dysfunction, but he want to talk about high blood pressure. In fact, his pressure was low. So if you just listen to that and you say, oh, well, your pressure is not high, so you don't need any high blood pressure, and then move on, then you already miss about his sexual history. And potentially you may miss some type of STD, sexually transmitted disease that he may have. Or even if you don't examine his genitalia, then, and you give him Viagra, you may end up miss a diagnosis here. And with that STD, you may also figure out that his partner, I mean, his wife, his girlfriend, or even a male partner may have STD. And that investigation will lead in other questions. So just to tell you, become a very curious mind when you see a patient, no matter what, because I believe there's always an interesting story behind. And if you truly focus on the occur patterns, you will find. All right, so Dr. Dana, we talk about OLD, we talk about characters already, and exorcist symptom already. Now, the R, a lot of people start with relieving factors, and also this is the relieving factor is different than treatments. Okay, a lot of time you guys think that, oh, I'm taking acetaminophen and that help. That treatment is not relieving factor. Okay, so what is relieving factor? Relieving factor, for example, people have back pain or people have osteoarthritis. They, excuse myself, then when they have that, they will have less pain if they rest. It's simple because the cartilage between the bone has broken out. So if you don't do anything, you feel better. So that relieving factor. Versus any type of chest pain, if people in chest pain and they try to do more activity and have more pain, that means oxygen demand increase and the cardiac, the heart did not have enough blood supply or oxygen. So that it's relieving factor or not. So they rest if you would rest. So the other thing that with relieving factor is interesting is if the patient laying down versus patient sit up, which is standing. A lot of time when we see a patient, they sit down already. For example, if they have headache and have vertigos and they feel better when they sit down, but when they stand up, they feel the room is spinning, the room they feel like walking an uneven factor. And then when they sit down, they feel better. So those are relieving factors will tell you that, okay, what if the patient sit down versus stand up? Now, when we move into between relieving factor and T like treatment, a treatment is the one that you take medication or anything that, for example, physical therapy is considered a treatment. Okay, if you have back pain and somebody give you a massage or whatever and you feel better, oh yes. So it's more likely a muscle or a tendon sprain, and then you have some massage, something that, and then you feel better. Okay, and then I think that we cover everything. Oh, one more about the S. Who you want to share with us about S?
I think because S stands for severity.
Mm-hmm.
To me, it's a nonsense to put the S there because I like to put the S in the C character rather than the S. Okay, we maybe have a different idea, but I just want to go back a little bit about the relieving factors and aggravating factors. Mm-hmm. Because in those factors, the most important to me, that is the position of the patient or the movement of the patient. Okay, you can say that the patient maybe that they are eating something or I do something, but mostly that you have to look at it, what is relation with the patient's position or the patient movements to the relieving factors or aggravating factor. And even it's not any relation at all, that's a good cue too, to think something else. So negative size or positive side all have the all value there.
I see. All right, so let's move on and see. We have Joe. Joe, you want to join us today, or you just want to watch? Hello, Joe. Can you hear us?
Yeah, sorry, I just want to watch. Sorry.
Okay, that's okay. That's completely fine because I know it's quite late in Vietnam right now. It's almost 11:30 p.m. and most of you are sleeping. But that's surprising.
Now I'm still study, but it's the first time I join the join this activity. So I just want to watch first, and then later maybe I will ask some things. Yeah.
Okay. So here's my recommendation. Since you already spoke, why don't you just talk about yourself a little bit? This is like no pressure, okay? This is nothing else, and you don't have to come on your camera too. That's okay. Yeah. So tell us about yourself.
Yes, I'm at the moment I'm live in Da Nang, and my major is pediatrics. I work in Da Nang Hospital for Women and Children at neonatal unit.
Okay, so you are a cardiologist.
No, a neonatologist.
Oh, neonatologist.
Yeah.
You know, it's funny about the ologists that did you guys know that what is cosmetologist is?
No.
No, and then you know what a cosmetologist, right? I know. Oh, really?
It's not cosmic. It's not like a plastic surgeon.
No. Cosmetologist. Okay, and
Cosmo, like a space, eh?
No. So cosmetologist. Initially, I thought just like you. I thought, okay, maybe cosmetologist is something like cosmetic surgeon. No, cosmetologist is it's a general term for hair makeup or someone facial makeup, and it takes you a couple of weeks to become a cosmetologist. To learn in California, that we have a cosmetology school, then train you to become a hair makeup about some makeup. So this is cosmetic. It's cosmetologist. So sometimes
they are not medical doctors.
No. So one thing I learned that actually not all ologists are doctors. Okay, like a while ago, for example, Queen, it's one of VietMD instructor. He's here, electrophysiologist.
Mm-hmm.
And not many people know exactly what this electrophysiologist because his name is too long. And by the way, since you are a neonatologist, there is a subspecialty thing that's called electrophysiologist, neonatologist. Mm-hmm. So basically, it's the long name means this is a doctor that specializes in baby just born with a cardiac problem, particularly the electrical circuit.
Yeah. In Vietnam at the moment, it's still quite generally, not very specific. Maybe in the future, we can more specialized in smaller aspect.
Yeah. It's only that yesterday when I look at the JAMA, that someone proposed a new specialty. I said, are you kidding me? We have 120 medical specialty in the US already. Well, almost 130 something. Some of them, someday we'll talk about some of the very funny one that they train very few doctors a year. One of them called aerospace medicine. This trend only in Texas. And I'm sure you know that aerospace medicine is the branch of medicine deal particularly with aerospace up there. I don't know how many patients will go up there, but so aerospace medicine it's coming up, and the other one is it's particularly called female reconstructive surgery. In this particular, especially their job is they do vulvoplasty. So they reconstructed the outer part of the genitalia, in particular for women. They make it instead of making the face look young, this is some idea out there. Okay, all right. So Joe, so are you're a doctor now, right?
Yes.
Could I talk a little bit? Okay, maybe out of the topic, but about the pronunciation of our specialists. Sometimes it's very tough to pronounce it. Okay, for example, like myself, I was anesthesiologist before, but sometimes they just make it short. They say that anesthetist, like in UK, you just say that anesthetist. You don't say anesthesiologist. It's a very American name. But however, when you tell somebody that you are anesthetist, sometimes they make confused with aesthetic. That is, what is it? Thẩm mỹ mà it's not. They are not doctor. In your case, like say that you are neonatologist, but at the same time, you are pediatricians. It's very hard to pronounce it because we have the group of Da Nang doctors who study medical English with Vietnamese. A lot of people cannot pronounce correctly pediatricians. Okay, so it takes time to make sure, because when you are in your profession and your specialty, you try to pronounce correctly your specialist name. Okay.
Yeah, thank you. Yeah.
You're very welcome. Yeah. Hello, Win. Where are you? Anyway.
I'm here. I'm trying to have my breakfast before
okay.
my
Still early, still early in California.
And then has a good point about very good question about naming of specialists, because one time you realize that if you even yourself cannot spell out or pronounce correctly your specialty, how will you expect other people spell or correct or pronounce your specialty? So I told my student, whatever you're going to, you must be able to tell who you are. One of the funny one is ENT. I mean, here in the US, we call ENT doctor all the time. You know why? Because very few of them can pronounce the word otolaryngologist. Okay, so that's the name. It's called otolaryngologist. And sometimes the other one, I didn't mention it, anesthesiologist. And the one that one of my favorite one is like electrophysiologist. It's a good one to start with because it's quite long. So think about it. Okay, and neonatologist is a very okay one.
Say the same like ophthalmologist. People don't say that. People just say, "I'm an eye doctor." It's easier for everybody. Yeah, but really they have to say that I am ophthalmologist.
Well, when you say you're eye doctor, actually you may refer yourself as an optometrist, not ophthalmologist.
Yeah.
And the reason between the two is quite different. Optometrist is not a medical doctor. They also a doctor, but they specialize in optometry. That means the outer part of the eye. They focus on eyesight. Okay, they measure eyeglasses, but they don't do surgery, and obviously they're not a medical doctor. While ophthalmologists are MD or DO, they went to medical school and they have at least 4 years of training in residency and or fellowship. So to tell you that's so important, when I ask my student introduce themselves, make sure they can tell me what is their specialty. The other common one, gastroenterologist and proctors. And then the other one is, virtually you hepatologist, the liver specialist. So a hepatologist and also a gastroenterologist, but also an internist. So if you look at that, an internist is a broad term for any type of internal medicine doctor, include cardiology, rheumatology, or even dermatology, used to belong to internal medicine. Surgery is also the different animals. So surgery, within surgery, you have different type of surgeon, but neurosurgeon, orthopedic surgeons, cardiac surgeon, but all of them are surgeons. Very similar to everything here, like you, neonatologist, you are pediatrician to start with, and then under that pediatrician, you divide it.
Something we have to differentiate between psychologists and psychiatrists, because it's very blur. Some people just mix up with those. So you be very attention to see that psychiatrist is a medical doctor. Meanwhile, psychologist is not. Okay, even that we have to call them doctor too, because usually they have a PhD.
Yeah. Psychiatrists actually for the past 15 years, they get more and more. No, actually, psychologists more and more of them get the Psych D degree, so I mean doctorate of psychology, instead of PhD in clinical psychology. The reason being because they try to make themselves more like a PharmD or professional doctorate versus a PhD. But that movement has stopped a couple of years ago. I'm not sure why, but a lot of them dealing with insurance, and everything in the US go back to money. Believe it or not, it's money talk, and that's where how far your specialty going depends on how good you are in terms of when you lobbying and when you like to say, oh, I'm a psychologist, but now I like to prescribe medications, and that will make a big fight. You know why? Because that's where the money is actually. A psychiatrist make about 2 or 3 times salary compared with a psychologist. The main reason why they make more money because they were able to prescribe medication versus psychologists do not. And some of the psychiatrists, they also do procedure. And some you may not know this, but one of the common procedure that a psychiatrist doing is they do a electrical stimulation to the brain for severe depression. So, I mean, one time I saw a psychiatrist doing that. I say, really? You know why? Because they wear like a surgeon. They wear a scarf and they do this. I said, Jesus, this is somebody never do a surgical procedure because if you do it so many times, you probably don't need that. Mm-hmm. Very high end. But it's funny because a lot of time internal medicine or a psychiatrist in this particular case, when they're doing procedure, they put a gown in, they put a cap, they do so serious versus a true surgeon when they do a big major thing, and even with abdominal, they do wound changing. There's nothing, just a mask and with two gloves. Just to tell you how funny we are. Yeah. And so back to Din's story, and I think we're gonna end up maybe in 8 minutes because.
Okay, now Win, because we have free time and nobody asked us any question, we may move to the. I think it's a very interesting topic too. It's about the clothing, because you see people just discuss about why you have the scrubs or not scrub or white coat or something. Yeah, because in Vietnam, sometimes had to put they wear the scrub clothing, and they go out and do shopping or do something. Yeah, so it's very in Ottawa where I work. Yeah, never wear scrub go out to do something. Yeah, they just limit it in the hospital, or sometimes some people don't have the we call the blouse or the white coat too. So how do you think about that? Because maybe in California there's different practice from that.
Well, you have to realize that actually there's 2 types of scrub. The one is called surgical scrub, the truly scrub that you use in OR, like Andy mentioned. The other one is called look-alike scrub. So look-alike scrub, nurses use it. I mean, all the healthcare professionals, ED look at that too. A lot of ED doctors, they wear look-alike scrub. You know why? Well, first of all, surgical scrub actually is completely sterile, and that you cannot take it out with the OR. You have to have a process of recycle, clean, and then sterilize. And with very serious stuff here. But the look-alike one, it just makes them feel comfortable, and then they can wear everywhere else. And I think here in the US, I even myself or my colleagues, I did a couple. I work sometime in the ED or urgent care setting, and I wear scrub, but I know it's a look-alike scrub. It's not truly the surgical scrub like and didn't say. So what look-alike scrub means? I mean, the public look at you, you're cool. Well, the reason I wear it because it's just convenient. Actually, I don't really care what people think. It's for me, go out there, buy something, get back. But I don't think it's appropriate to wear a true surgical scrub, go out there. But I think if look-alike scrub, sometimes I think it's okay. But if I have time, I prefer not to wear it because, one more thing. Look-alike scrub, it's actually like a pajama, okay? So that means what? If you are a girl, you may look very sexy with that. And you have to be careful though, because it's a pajama. That means the material and everything is suited for inside. It's not go outside. But sometimes I saw that people, while they go and they spend the whole day with that pajama. But anyway, I think it's up to that person. But the true surgical scope, they should not ever leave the OR. And the hospital, they know that. But the localized scope, I think it's okay. Even with my office here, my staff also, they wear scope because some of them assist me with procedure. So what do you think, Andin? Or actually, let's ask Joe.
Yeah. Joe, what's in Da Nang? Can people do have the scarf and go out or do something in the OR or something?
No, sorry. The problem is I don't know exactly what you discussed about.
Oh, I'm sorry.
Sorry.
Okay.
All right, that's a very good excuse. So we were talking about surgical scope. When you go into the OR, right, you have to wear. You have to change your clothes into a scope. I mean, a uniform that only in the OR. Then if you in that, and when you get out of the OR, you have to change. But some people, they like to wear it. I think another thing, it's also come from media, like Dr. Oz. He's a cardiothoracic surgeon, but sometimes he go to his show and he wears scope. I think it's cool too. But then nurses and also AD, emergency doctor, is the one that use, and they try to make the distinction as a specialty uniform, because the ED look-alike scope are not truly surgical scope, but also to show people that, okay, I'm an ED doc, I'm convenient, and I don't wear long coat, I don't talk a lot, I just finish this and move on to the next one.
Oh, thank you. Now I see. Yeah, here I often use the uniform to describe that we often wear. Yeah, and I work in neonatal unit. That means NICU and ICU. So we have the special uniform. So we just wear that uniform inside the NICU. So whenever you go out, you have to use a white coat like you are wearing. Yeah, to go inside the hospital. But if you go out of the hospital, you have to change into casual wear. Yeah.
Well, it's funny that Andy mentioned that. I think one of my professor, he retired. It's almost retired. He said, when you were young, you were a student, you like to tell the people that you are a doctor. So it's really the wear thing that make you look doctor all the time. And even if you, especially for those just accepted to medical school, okay, you really want to tell the world that, oh, you are the best doctor, or you're going to be the best doctor. When you graduate from medical school, you change a little bit. You still want to tell people that, oh, you're a doctor, but a little bit more conservative. When you finish your training, your residency, you think of, okay, well, I'm not sure. You become, okay, you train further and finish fellowship. You think, okay, well, the point is when you get older, when you get about his age, 60-something years old, and he said one time he was on a flight, and the flight attendant said, is there a doctor on board? And he really want to say, and he really want to help someone else raise the hand before him. Unfortunately, there's nobody except him, so he had to say that. But the moral of the story is we change our perspective all the time. And we, even with our career. So hopefully by you and me or whoever get to the age 60, we still want to tell the world that we are a doctor, but not to the point that, okay, well, I wake up all the time to tell the world I'm a doctor too. So I think that it's okay.
Yeah. You know, according to statistically, almost every flight or every cruise, you have doctors there.
Yes.
It's usually that. So that's why the airplane company, they don't never recruit the doctor on the plane, because they know right away that there's some doctors in the plane. So they just make announcement. It's very interesting. Say that in the cruise too, because the cruise has 1,000 people there. Should be some doctors, some nurses, some specialists there. So they just make announcement. But the cruise, they always have one doctor and one nurse to take care of the whole ship. but in the airplane, no. So it's a very interesting thing. And many accidents happen on the flight. And usually some doctors show up at the time.
Yeah. It's one more thing, like it's not because they know it, but actually in my profile, United know that I'm a doctor too, so very easy for them to pull up. One time I was called for, but there's nothing there, and that to the other doctor on board too. One thing that I didn't mention is if you ever fly on a plane and if you see a doctor, the one doctor that two doctors that you don't really want to see. The first one is the pathologist. The pathologist is the one that you know who it is, right? So they did autopsy. So they the one that specialize in disease after people die. So you don't ever want to have a pathologist come to see you because pathologists treat dead people that don't treat. Well, this is the other thing. They look at the slide, look at biopsy, but pathologists they interest more in that. And the second type of person that you really want not to see during a flight, if you have a cardiac attack, is psychiatrists. Because psychiatrists, they will come and say, are you depressed? You feel sad? And then, well, why you have a heart attack? Of course, I don't know what else you to say, but I'm just kidding, okay? So out there, if you guys are pathologists or a psychiatrist, this is teasing, okay? Of course, you can come and help out. But one thing that will make why I said that, because pathology they don't do internship. So that means after medical school, the last patient they ever encounter is during their medical school. That's it. They go straight to the lab, to the morgue, and dissect people. While psychiatry, yes, you still see real patients, but I think the last one they did 1 year internship in internal medicine, and then they focus 3 years. All right, and I think I'm gonna go. And Joe, thank you very much. I think today it's kind of very late in Vietnam, so hopefully next time I try to do earlier. But hopefully I see you guys soon. And then any other comments, Joe, before I close this?
Just a little bit, okay, if you have time. Just back a little bit about the uniform, about the color, very quick one. Because in the old day, all people wear white.
Yeah.
And then I think that during Vietnam War, they turned to Attire. It's like a black, blue, green. Okay.
Green, yeah, blue,
And now in the hospital, they have all color, have like a Mickey Mouse or flowers, everything. And the color is quite different. So I just asked you in Da Nang, you still use the one color or different color for different departments?
Oh, yeah, it depends on the department you work. For example, in my department, we have 2 colors, pink and dark green.
Okay.
Because we have to change every day. So, for example, Monday, Wednesday, Friday, dark green, and then Tuesday, Thursday, and Saturday, pink.
Oh,
yeah.
Wow.
Yeah.
I don't know what's the rule there.
We choose pink, because it changed. It just changed about recent 2 years. Yeah. Yeah.
The reason behind that, okay? Yes.
I'm not sure is there any underlying reason.
Okay.
Yeah. But
Because
we just would like to change.
In Ottawa Hospital, different section have different color. Say that the doctors have the different color, and the PSW is like a worker. They have different color. They don't want the patient confused between the title.
All right, guys, I have to go.
Yeah.
But, thank you very much for
today. Bye bye. Yeah.
And hope to see everyone soon. Thank